On preterm labor, preterm birth. First MCQ is the which of the following drugs act by increasing intracellular cyclic AMP, so thereby reducing free intracellular calcium and inhibiting uterine contractions. So basically, you have options atosiban, indomethacin, nifedipine, tolbutamol. So basically, the mechanism of drugs they are asking this question. They are asked for drugs that acts by increasing intracellular cyclic AMP, and that will reduce free intracellular calcium level and inhibit uterine contraction. The mechanism it's not by atosiban because it is the receptor. Okay, it is not by indomethacin, but answer is tarbutaline. Okay, because you know beta 2 agonist, ritodrine and tarbutaline it activate adenine cyclase and it increase cyclic MP and activate protein kinase A, decrease myosin light chain kinase activity, and it also decrease intracellular calcium that will cause relaxation of uterine smooth muscles. And but if you see nifedipine, it will block calcium channel, and atosipan block oxytocin receptors, not the cyclic MP mechanism that will reduce intestinal calcium inhibiting uterine contractions. And everybody is know that indomethacin has action that will inhibit prostaglandin. So basically the reference is for Mullum stochastic addition. So this question, which of the following is drugs act by increasing intracellular cyclic MP thereby reduce the intracellular calcium by inhibiting uterine contractions. The next question, the MCQ number 2, regarding atosiban, which of the following statement is true? It is a decapeptide oxytocin analog and oxytocin receptor antagonist. No, it is a this option is not. It is a oxytocin receptor antagonist is correct, but it is a not a decapeptide. Actually, it is a nonapeptide. So atosiban is a nonapeptide. Then second option, it oxytocin antagonist and directly reduce the uterine contractility. This we will see. It is contraindicated women with asthma. This correct statement. It is not a correct. It is not contraindicated. It, the first line isn't recommended all international guidelines. So basically, if you see the options, oxytocin receptor antagonist is correct. Atosipan is a nonapeptide. It is not a decapeptides. The FDA has denied approval of atosiban for use in the USA because it was linked to its significant neonatal morbidity. So option B is the correct statement. Oxytocin antagonist directly reduce the uterine contractility. The MCQ number 3. Which of the following statement correct regarding tocolytic? Tocolytically significant reduce neonatal mortality. It's absolutely correct. Don't reduce neonatal mortality. Okay, not correct. The none are approved for long-term use beyond 48 hours. Beta-mimetic is safe than calcium channel blocker. Indomethacin is contraindicated for up to 24 weeks more. So if you see the options, tocolytic don't reduce neonatal mortality, but major action of tocolytic is it will allow the transport to obstetrical center and permit time for a course of steroid therapy, not to reduce mortality. It's to give a steroid course. Okay, calcium channel blockers are safer than beta-mimetic is correct statement. Indomethacin is contrary after 32 weeks. So option only it used for not beyond 48 hours. It should use for only 48 hours till the steroid coverage. Okay, none of the are approved for long-term use. Okay, this statement is correct. With the following statement is false. Tocolytic stop contractions temporarily but rarely prevent preterm birth. Maintenance therapy with tocolytic is effective for preventing preterm therapy. No trial has ever convinced or reduced rate of any adverse outcome by tocolytic compared with placebo. Out of beta-mimetic drugs, only ritodrine is FDA approved for preterm labors. So basically the answer is B, false statement they are asking. So tocolytic stop contraction temporarily but rarely prevent preterm birth. So tocolytic is stop contraction temporarily but rarely it will prevent preterm birth is the correct statement. And the no trial, there is no trial that will cause a significant reduce the rate of any important adverse outcome by tocolytic compared to placebo. And out of beta-mimetic drugs, only ritodrine is approved, FDA approved, rest are not approved. And maintenance therapy is effective, not effective, is ineffective for preventing preterm birth. Okay. So MCQ number 5, this is a 26-year-old primary gravid 29 weeks gestation present with regular painful uterine contractions. Basically, her cervix 2 cm dilated, 50% E phase. Diagnosis of preterm labor is made. Her past medical history is significant. Generalized myasthenic gravis. So basically, this is a myasthenic gravis patient, which is pyridoxine, and she is authorized to stable. The team is considered delayed delivery. So what is the drug of choice for the if patient is a myasthenic gravis? What is the drug that contraindicated? Basically, the magnesium sulfate you should not give those patients with myasthenia gravis because the MAC self is interfere the neuromuscular transmission that will cause risk of severe muscular weakness and respiratory failure in patient with myasthenia gravis. So MAC self is contraindicated in these patients. Next questions, MCQ 6. 28-year-old G2P1 30 weeks treated with indomethacin tocolysis for 48 hours to allow correct coverage. She delivered 30 weeks 3 despite therapy. On day of 5 of life, baby you develop abdominal distension, bloody stool. That is basically this whole of the clinical picture is presenting with the necrotizing enterocolitis. So what is the statement that is mostly mechanism? Basically the decrease mesenteric blood flow due to prostaglandin inhibitions, because you know prostaglandin inhibition, the mechanism as for indomethacin reduces prostaglandin synthesis, decrease mesenteric perfusions, predispose to neonatal necrotitis enterocolitis. This is the correct statement. That is, it will increase prostaglandin synthesis, decrease mesenteric blood flow due to prostaglandin inhibitions. Okay, so option B is correct. Next questions. MCQ 7, 20 primary graduate 30 plus 1 weeks is admitted with retina preterm labor. She started on indomethacin as tocolyzer to 40 hour. Ultrasound show amniotic fluid index is 6 cm. Previously it was 12 cm. Fetal Doppler is normal. The patient is otherwise stable. Contraction have been subsided. Steroids for long maturity are complete. What are the most appropriate next step management? So basically this is the continued indomethacin, as already usually not drug related within the therapeutic days. Discontinue immediately, switch to nifedipine, montelukast, add metal hydration, start atosipin in addition to. The answer will be discontinue indomethacin, immediately switch to nifedipine and montelukast, because you know indomethacin will reduce fetal urine productions and it will decrease AFI oligohydramnios. This effect dose dependent but can occur even at therapeutic level. Also detected early by ultrasound. The oligohydramnios is usually reversible within 24 to 48 hours of stopping the drugs. Continuing indomethacin risk worsening oligohydramnios and doctor's constriction. So metal hydration does not reliably prevent this effect. So dual tocolysis is not recommended. So basically the option, if you see, you have to discontinue immediately because there will be a decrease AFI drastically, and you have to switch to other drugs like nifedipine. You have to start and you have to discontinue the indomethacin therapy. Next, FCQ number 8. This is 32 years old G3P1 L1 31 x 4 days admitted preterm labor. She has a gestational diabetes on insulin, mild mitral stenosis, is on methyl dopa for hypertension. Cervix is 3 cm dilated, membrane insulin, no infection. Steroid is planned. Most appropriate tocolytic. So basically you have to give atospan because oxytocin receptor antagonist. You see, this is the heart disease patient. Basically the drug of choice in heart disease patient is safest is cardiac disease patient is atospan is the safe drug. Metal diabetes, hypertensions the indications for atospan. Rest nifedipine normally the first line normally usually will give you a preterm labor, but caution with cardiac disease because in mitral stenosis and antihypertensive the risk of severe hypertension and pulmonary edema is higher in if you start with nifedipine. And the ritodine, the contraindicated in cardiac disease and diabetes. Risk of arrhythmia, pulmonary edema, hyperglycemia is more in ritodine. Indomethacin can be used if less than 32 weeks but not ideal in mother with cardiac morbidity nearing towards 32 weeks. Risk of ductal constriction, necrotizing enterocolitis is high. So number question 9 is 29-year-old G for P0, 3 previous painless mid-trimester preterm birth. She had a McDonald's circus last pregnancy 12 weeks but aborted 24 weeks. TVS so cervical length is 40 mm. She desired maximum chance of viable pregnancy. What is the best management? Because here you can see they have a put a previously McDonald and now that also failed. So in case of if history of clear indication of transabdominal circulasis, if there is a history of failed prior transvaginal circulasis, you can go for a transabdominal circulasis. TVS length is normal but history is overhead in the cervical length here. So cesarean delivery is mandatory after trial of cesarean sections. So basically repeat transvaginal circulasis at 12 weeks, vaginal progesterone no rules, or transabdominal circulasis before conception or early pregnancy. Okay. Number 10 questions. Number 10, 20-year-old distributed private and bath, 29 days, TVS cervical line 17 mm with funneling but close length is more than 25 cm as per circulasis is indicated. What will you please? So basically there will be no intervention because you can funneling without cervical less than 25 mm is not an indication of circulasis. Guidelines specifically warn against over intervention. So there is no interview because there is funneling. If only that less than cervical length is 25, then only go, but funneling without length normal length. So only funneling is not an indication for a cervical circulasis put.